Welcome to the Black Belt Nurse Podcast, where we discuss all things related to violence in healthcare. I'm Bill Schuler, your host, and this is the place where we learn together, mull things over, and generally figure things out. Whether you're a seasoned expert, a student, or just passionate about safety in healthcare, this is the podcast for you. Before we dive in, a quick disclaimer. We do discuss all aspects of violence in healthcare, some of which may be inappropriate for younger listeners and viewers. Please use discretion. The Black Belt Nurse Podcast is for informational and educational purposes only. While we discuss experiences, strategies, and science, this podcast does not provide medical, legal, or professional advice. Always consult your healthcare institution's policies and guidelines or seek professional advice when necessary. And of course, all opinions expressed here are my own and do not represent any employer or organization. Now, let's get started. Today, we're tackling how one health system evolved its process for identifying patients who may be at risk for violence, and why how we flag matters just as much as whether we flag. We're going to walk through two versions of a risk for violence flagging process, the original and the updated. Pull out the 10 most important points from each, and then compare them head-to-head on 5 critical dimensions. Let's get into it. Before we get to where this system is going, we need to understand where it came from and why it was built in the first place. The story of the original risk for violence flagging process at a U.S. health system is a story that a lot of nurses will recognize. A real problem, a motivated team, and a first-generation solution that did a lot of good and left room to grow. The electronic health record introduced flagging capability in 2018. At that point, there was no standardized process for communicating risk for violence to care teams. If a patient had assaulted staff on a previous visit, there was no reliable way to ensure the next team knew. Bedside caregivers couldn't even place a flag. Activation was limited to managers, assistant managers, house supervisors, social workers, security, and quality staff. Frontline nurses were largely left outside of the process. So in 2019, a task force was convened, a subgroup of the Violence Prevention Committee that included security, safety, patient safety, behavioral health, emergency nursing, home services, informatics, and nursing education. They did a literature review, designed a process, sought approval, and launched it as a small test of change using the PDCA cycle, which stands for Plan, Do, Check, Act. That methodology matters because it means the process was designed to be iterated or changed, not just implemented. What did the literature tell them? 3 key findings shaped the original design. First, from the Public Services Health and Safety Association, flagging is a proactive approach. It should be a routine part of violence prevention, used post-incident to prevent future events, and always paired with risk assessment and care planning. Flags should communicate the level of risk, known triggers, and safety measures. And they must be audited systematically for appropriateness, accountability, and quality control. Second, from Patterson and colleagues in 2019, when flags were present, caregivers interacted with more vigilance, actively sought out information on how to manage risk, and initiated care plans. The research also showed a decrease in the number of violent incidents and incidents per patient after the process was initiated. Importantly, the research noted that flagging isn't just for nurses, it's for all support staff, which includes housekeeping, nutrition, security, everyone in the care environment. And third, from Farron and colleagues in 2021, major challenges in flagging programs include stigmatization, patient privacy, and gaps in policy and procedure. And there's a counterintuitive finding worth naming. Hospitals that try to exempt mental health patients from violence prevention programs in an attempt to avoid stigma actually stigmatize these patients more by treating them differently than everyone else. And simultaneously, they put workers at greater risk. The goal, the literature was clear, is not to label patients. It's to communicate that a risk exists. Here are the 10 most important points from that original process. Point 1. The flag was born out of a genuine patient and caregiver safety gap. Before 2018, the electronic health record didn't even offer flagging capability. When it became available, there was no system, no standard, and no process. The original flagging effort was a direct response to caregivers being harmed because the next team simply didn't know that a patient had a history of violence. That's the foundation this whole system was built on. Point 2. Bedside nurses could not activate the flag. And that was a known problem from day one. Activation was restricted to a specific list of leadership and supervisory roles. Bedside caregivers, who were often the first to identify risk and sometimes the first to be harmed, had no direct pathway to place a flag. This limitation was recognized early and became one of the central drivers of redesign. Point 3. The original process launched as a small test of change using PDCA methodology. The team didn't try to roll out a perfect system to 8 hospitals at once. They started small, implementing at 2 hospitals first, then expanding. This approach allowed for learning, feedback, and adjustment before scale. That discipline is part of why the outcomes were ultimately strong. Point 4. 3 alert levels guided the intensity of precautions. The original system used levels 1, 2, 3, and 4. Level 4 was the highest risk. Each level corresponded to recommended actions for the care team. However, the criteria distinguishing these levels weren't always clearly defined or consistently applied across the system. Point 5. A violence risk mitigation note was required with every flag. Caregivers were expected to document the rationale for the flag, the alert level, identified triggers, warning signs that a patient may become imminently violent, and specific caregiver tips. This was a meaningful attempt at actionable documentation. But early feedback revealed that adding that documentation individually was cumbersome. Caregivers found it burdensome, which affected utilization. Point 6. Initial feedback showed modest but real impact on caregiver safety perceptions. Early check-in data showed 30% of caregivers felt a little safer and 15% felt much safer after the process launched. One caregiver described it this way: they didn't use the flag to judge the patient, but to prepare themselves for safety measures and to identify the patient's triggers so the patient could have a smoother healthcare experience. That framing, preparation not judgment, was exactly what the process intended. Point 7. The process was actively updated based on what wasn't working. After the initial implementation, the team acted on their findings. They reduced the alert levels from 4 to 3, clarified language at each level, rolled out to all nursing units, and refined the appeal process. They also advocated to informatics for an automated activation and deactivation process, a recommendation that was eventually incorporated into the next generation of the system. Point 8. Auditing was built in, but it was manual and resource dependent. The original audit process relied on dedicated people reviewing flags quarterly at a regional level. The goal was to catch inappropriate placements and flags that weren't deactivated at discharge. It was a thoughtful accountability measure, but it depended on human bandwidth, was not automated, and could not scale easily. Point 9. The system produced significant, measurable outcomes. This is worth pausing on because the outcomes were remarkable. After the first 4 years of implementation, there was a 160% increase in the risk for violence flag activation, meaning the system was being used. There was an 81% decrease in flag errors between 2023 and 2024. Most critically, a 45% decrease in workplace violence injury rate per 1,000 FTE in 2023 and 2024, a 39% decrease in workers' compensation claims due to workplace violence, more than a 50% decrease in lost workdays since 2020, and approximately a 50% decrease in the total cost of workers' compensation claims since 2020. These are not marginal improvements. They represent real reductions in harm to real people. But keep in mind that it is hard to pull out how much of the flagging process influence the decrease in harm and costs. Point 10. Oregon's Senate Bill 537 compliance requirements shaped and strengthened the process. Oregon law, Senate Bill 537, established specific requirements for violence flagging systems. Those requirements include criteria and processes for initiating, continuing, deactivating, and reactivating flags, training and education for all initiators, including bias identification and prevention, and a formal appeal process for patients. Critically, the law specifies what may not be done based solely on a flag, including denying admission, restricting access to care, contacting law enforcement, or punishing a patient. Building these protections into the process wasn't optional. It was a legal and ethical floor, and the team built the process above it. The original process was a genuine first-generation achievement, a literature-informed, multidisciplinary, PDCA-driven system that produced substantial reductions in caregiver harm. Its limitations: restricted activation, no validated assessment tool, manual auditing, cumbersome documentation, were not failures of intent. They were starting points for what came next. Now let's talk about the updated system, a formal policy built from months of multidisciplinary task force work and grounded in evidence. This isn't just an incremental tweak, it's a structural redesign. Here are the 10 most important points from the new process. Point 1. The updated system introduces 2 distinct flags, not one. Now, this is a fundamental change. The new policy separates the history of violence flag from the risk for violence flag. The history of violence flag is placed manually based on a verified history of violence, and that can include physical assault, sexual assault, intentional property damage, or attempts at harm in a healthcare setting. It lives in the chart permanently, independent of any current encounter. The risk for violence flag, on the other hand, is encounter-based and driven by the Violence Assessment Tool Score. These 2 flags serve different purposes and can be active simultaneously. Separating them adds precision and reduces the risk of a historical event permanently coloring every future interaction without clinical context. Point 2. The Violence Assessment Tool, or the VAT, is now the required engine behind the risk for violence flag. The VAT is adapted from 2 validated instruments, the Brosette Violence Checklist and the Dynamic Appraisal of Situational Aggression, or DASA. It assesses observable behaviors: confusion, irritability, verbal and physical threats, agitation, paranoia, substance withdrawal, and specific body language cues, and scores them numerically. No VAT assessment, no risk for violence flag. The tool must be completed to activate the flag. That's a hard clinical gate. Point 3. The VAT score directly determines the flag color and what happens next. A score of 0 means no flag. A score of 1 to 3 is moderate, a yellow flag. 4 to 5 is high, an orange flag. 6 or greater is very high, which is a red flag. And here's an important operational detail. The very high flag persists for 90 days after discharge before automatically deactivating. The others deactivate upon discharge. That 90-day window ensures the next care team isn't starting blind for patients with the highest risk profiles. Point 4. The policy explicitly states flags will not be used to create bias or deny care. The policy language is direct. The flags will not be used to create bias, including denying access to care that patients would otherwise receive. That's not just a value statement, it's a policy boundary, and it reflects a mature understanding that flagging systems, if poorly designed or monitored, can become instruments of discrimination rather than safety. Point 5. RNs are now empowered to initiate the risk for violence flag assessment directly. All registered nurses, along with charge nurses, house supervisors, nurse managers, and assistant nurse managers, can place the risk for violence flag. This is a significant departure from the original process, which excluded bedside nurses from activation. By empowering nurses, the policy puts the assessment capability in the hands of clinicians closest to the patient, which means faster, more timely flagging and fewer incidents slipping through because the process was too cumbersome. Point 6. The history of violence flag has a separate, more restricted activation pathway. Security, charge nurses, house supervisors, nurse managers, and assistant nurse managers can place the history of violence flag, but regular staff RNs cannot. This makes sense given the permanence of this flag. It requires a higher threshold of review and accountability because it follows a patient across every future encounter indefinitely. Point 7. Reassessment frequency is tiered by risk level. A moderate score, 1 to 3, prompts reassessment as behaviors change. A high score, 4 to 5, requires reassessment at least once daily. A very high score of 6 or greater requires reassessment twice daily. And if a patient scores 7 initially but drops to 3 on reassessment, they shift to the lower reassessment frequency. The flag responds dynamically to the patient's actual presentation rather than locking in a static label. Point 8. Previous assessments, triggers, and care considerations auto-populate on reassessment. When a caregiver opens the VAT for a reassessment, the prior information is automatically filled in. The caregiver can accept it, edit it, or update it. This reduces documentation burden while maintaining continuity, and it keeps the care plan current rather than orphaned from the assessment process. Point 9. The VAT is explicitly not validated for pediatrics, and the policy says so. The policy clearly states the VAT should not be used for pediatric patients. Rather than applying an adult-validated tool to a population it wasn't designed for, the policy names the gap and defers to future work to identify an appropriate pediatric tool. That kind of intellectual honesty about a tool's limitations is a mark of a responsible, evidence-based process. And point 10, training is formalized and tied to job role and care setting. Education on the risk for violence flag will be embedded in clinical education plans, aligned with regulatory and accreditation standards, and tailored by role and work area. This isn't a one-size-fits-all training module. It's differentiated, which increases the likelihood that caregivers actually know how to use the system correctly in their specific context. The new process is more rigorous, more fair, more dynamic, and more actionable. Now let's talk about why it's better, specifically through the lenses of fairness, bias reduction, and trauma-informed care. Here are 5 ways the updated process meaningfully improves on the original. Improvement 1. Separating the history of violence flag from the risk for violence flag is an act of clinical precision and an equity safeguard. In the original process, one flag did everything, but conflating a permanent historical record with a dynamic, encounter-based risk assessment creates exactly the kind of blunt instrument that can lead to bias. A patient with a violent episode 5 years ago during an acute psychiatric crisis should not be treated identically to a patient who is currently agitated and threatening staff. The 2-flag system acknowledges that history matters and that current presentation matters, and it keeps those 2 things from becoming the same thing. Improvement 2. The VAT anchors clinical judgment in observable, scored behaviors, directly addressing a gap in the original process. The original process had no validated tool, and the literature review that shaped it specifically called for risk assessment to inform flagging. The team knew this was a limitation from the beginning. The VAT doesn't eliminate human judgment, but it structures it. Caregivers are scoring specific, defined behaviors, not making a gestalt call about whether someone seems dangerous. That shift is meaningfully more fair. And because the original team advocated for this from the start, the new system reflects the maturation of a process that was always designed to grow. Improvement 3. The explicit policy prohibition on using flags to deny care codifies what Oregon law already requires and makes it visible. Oregon Senate Bill 537 was clear. You cannot deny care, restrict access, or punish a patient based solely on a flag. The new policy doesn't just comply with that standard, it puts it front and center. Trauma-informed care at its core asks what happened to this person and how we can respond without causing additional harm. A flagging system that could be used to withhold care, assign inadequate staff, or treat a patient as less deserving of attention perpetuates harm. Building the prohibition directly into policy language signals to every caregiver that this flag is a tool for better, safer care, not a reason to provide less of it. Improvement 4. Tiered reassessment frequency and automatic deactivation prevent the permanent labeling problem. The original system relied on manual audits, quarterly, conducted by a small number of dedicated people, to catch flags that had outlived their clinical justification. The new system automates deactivation for lower risk encounters and requires twice daily reassessment for the highest risk patients. A flag that once required human bandwidth to remove now removes itself when criteria are no longer met. No label is permanent without ongoing clinical justification. And lastly, improvement 5. Empowering RNs to initiate the assessment closes the utilization gap the original process created. The 160% increase in flag activation under the original system was impressive. But the system still struggled with underutilization, in part because bedside nurses couldn't act without going up a chain of command. The new process puts the violence assessment tool directly in the hands of RNs. When the caregiver at the bedside, the one most likely to notice agitation, verbal threats, or escalating body language, can initiate an assessment in real time, the whole system becomes more responsive. That timeliness directly translates to safer care for patients and safer working conditions for staff. So what's the takeaway for everyone watching or listening today? Flagging systems are not neutral. The way we identify risk, the tools we use, the people we empower to act, the safeguards we build against bias, and the training we provide, all of it shapes whether these systems protect caregivers or inadvertently harm patients through labeling and discrimination. What makes this story particularly compelling is that it's not a tale of a bad system being replaced by a good one. It's the story of a good system being made better by the same community of practitioners who built the first one, informed by their own outcomes data and the literature they'd been tracking from the beginning. The 45% reduction in workplace violence injury rates, the 50% reduction in lost workdays, the 81% decrease in flag errors. Those numbers represent real nurses who went home without injuries, real patients who received safer care, and real institutional learning applied over time. The evolution to the updated policy and procedure, 2 distinct flags, a validated assessment tool, tiered dynamic reassessment, and explicit anti-bias commitment in the policy language, RN-level activation, and formalized training is what continuous improvement actually looks like in practice. As caregivers, we don't just implement policy, we scrutinize it, improve it, and advocate for the systems that keep everyone safe, our patients and our teams. That's a wrap for this episode of the Black Belt Nurse Podcast. If you enjoyed this episode, don't forget to like, subscribe, and hit that notification bell so you never miss a new episode. Drop a comment below and let me know your biggest takeaway. I would love to hear from you. You can find me on LinkedIn and Facebook, as well as blackbeltnurse.com. For now, be safe, and I'll see you in the next episode.